Thank you, Declan. Morning, everybody. So as Declan said, I'm Karen Matvienko-Sikar from UCC. I'm really pleased to be speaking today about selection of outcomes as part of the Spring School. So you might be wondering why I'm speaking to you at the beginning of the Spring School on trial methodology about outcomes, which are typically something that we think about towards the end of our trial when we've conducted our trial and we want to see whether or not our intervention or our treatment worked. Well, among other reasons, the reason that I'm talking to you about outcomes at the beginning is because consideration of outcomes from the outset of our trial and throughout our trial is of critical importance for reasons that I'm going to talk about today. And while the title of the talk is Selection of Outcomes, I'm going to aim to do three things in the space of time that I have. So the first is to highlight and emphasise the importance of outcomes across stages in the trial process. The second is to highlight some challenges as well as some potential solutions to selecting and measuring outcomes in trials. And then the final one is just to kind of give that nod to the measurement aspect as well. So when I'm talking about outcomes, I'm talking about measurement or observations that are used to capture and assess the effect of a treatment. So there's lots of different ways that we can measure and that we can observe various things. We might use surveys, questionnaires, standard clinical measurements, we might have biomarkers, whatever they may be, but essentially an outcome is something that we are looking at to assess an effect of a treatment. Typically in trials we can think about primary outcomes and secondary outcomes. So the primary outcome is our target outcome for the trial. It's the outcome that we think is most clinically relevant to our trial. We typically tend to have one primary outcome. You can have more than one, but we typically tend to have one primary outcome. And it's the thing that's of most interest in the trial in terms of our intervention effects. Secondary outcomes, we can have obviously more than one secondary outcome. You can have one secondary outcome, but we typically have more than one secondary outcome. And those are other outcomes that we're interested in terms of trial effects. So they might be the effects of an intervention on something. It might be things like cost effectiveness. It might be things like adverse events or side effects as well. And thinking about outcomes, whether they're primary outcomes or secondary outcomes or both, as I said, is critical across different trial stages. I'm going to give one or two examples across multiple different trial stages just to give you a sense of the importance of outcomes across these stages. So when we're thinking about designing a trial, obviously it's really important that the outcomes that we pick to include in our trial are relevant to trial aims. And that seems kind of straightforward enough, right? We have an intervention or treatment. We want to design a trial and we want to see if the intervention or treatment works for something. So the outcome that we pick must be the best representation of that something. But it's critically important that we actually ensure that the outcome that we're picking is the best, the most appropriate and the most feasible outcome that is relevant to achieving the trial aim. And oftentimes that comes, so we have our aim and that leads to our outcomes. Sometimes we might be interested in an outcome, for instance, something like risk of mortality. But for reasons around practicability, feasibility, cost, or time, we may not be able to actually get at the outcome that we want to, and we may use something like a surrogate or a proxy outcome. So for instance, we might use something like risk of stroke as a proxy for risk of death or risk of mortality. In those instances, there's a kind of almost like a bidirectionality where the feasibility and the constraints of a trial can influence how we think about the aims and what we can achieve within the particular trial. There's also importance when you're thinking about the relevance of the outcome to the trial aims that the outcomes that we're picking are potentially responsive to the intervention. So there's no point in testing the effects of an intervention on an outcome if there isn't scope for that outcome to actually be responsive to the intervention. Okay, so thinking about the relevance is really important at the beginning. In terms of sample size, typically when people are designing their trials, they're thinking about their primary outcome, you want to make sure that you have sufficient power in your trial to be able to detect an effect on the primary outcome if there is one. So the outcomes can determine the sample size that you're going to calculate for your population. This will have knock-on impacts for a lot of the other things that you're going to do in terms of your trial. So how many people are you going to have to recruit? Where are you going to recruit them from? How long are you going to recruit them? How are you going to recruit them? So your choice of outcome at the outset is going to have real tangible practical impacts on what you're doing within your trial as well as getting your participants in. And tied to this, it's going to have impacts on the resources within your trial, what you're going to need to do to run your trial. So obviously things around recruitment, sample size, how you're going to get the people in, there's resources involved there. There's also financial implications in terms of the outcomes that we measure. So there was a recent review that was conducted by Heidi Gardner and colleagues where they reviewed, I think it was 161 trials where they were looking at the implications for kind of time and cost. And what they found was across the 161 trials that they looked at, there was a median notional cost of about £8,000 for collecting data on outcomes, but that this ranges hugely. So from little to no cost at all, up until I think it was about over £31 million in some trials. So the outcomes that you pick are going to have implications in terms of how you're going to collect data and from how many people, and that's going to have a knock-on impact then in terms of the costs that are involved, and often that isn't thought about as much. This then kind of flows into the conduct of the trial, so the outcomes that you pick are going to influence how you're going to, or will be tied to how you're going to collect data for those outcomes. This has implications for the time that's required to actually collect the data. So again, in that same review from Heidi Gardner and colleagues, they looked at the time that it takes to collect data on primary and secondary outcomes. So for primary outcomes, I think, and I'm going to do my best to remember these numbers correctly, it ranged from very little time at all up until about 11,000 hours for primary outcomes. So with a median number of around 56 hours for your primary outcome. Remember that we typically just have one. For secondary outcomes, because we tend to have more secondary outcomes, the range is much bigger. So it was from little to no time at all up until over 1.3 million hours for the time that was taken to collect data for those outcomes. That's a huge range. It's a huge amount of time potentially that you're going to spend, that the people who are running the trial are going to spend. It's a huge amount of time for how long the trial might actually run. It's also a huge amount of time for the participants. So if you're collecting data on lots of different outcomes, or you've got high frequency of data collection, or you potentially have invasive outcomes, there could be a lot of time spent by the participants actually engaging with that data collection process. So there's going to be a direct impact on the participants. And aside from just that direct impact on the participants, that can then impact on your trial as well. Because if participants perceive that there is a heavy burden in terms of data collection for the outcomes that you've picked, it might influence whether or not they sign up to take part in a trial. While they're in the trial, if they think this is too much, it's taking too long, this isn't worth my time, you run the risk of not retaining those participants as well. So the choice of outcomes is really important in terms of those kind of processes during conduct. And then this one kind of seems a little bit obvious. It impacts on our effectiveness. So the outcomes that we choose to measure are what will determine whether we can say our intervention worked or didn't work, or sort of worked, maybe we need to do a little bit more. So as I said, that seems a bit obvious, but it's actually really, really important, because our choice of outcomes at the beginning determines the only things that we should say about what our intervention or our treatment did. Okay, so we can only speak to the usefulness of an intervention based on what we decided to measure at the beginning. So what we decided and stated we would do before we began. If we did not select the most useful or appropriate measures and realize that after the fact, we can't say anything about those other outcome measures. So making sure that the outcome measures are relevant and appropriate at the beginning is really important. And this is really important not just for us as trialists and for the success or not of our trial, but it's important because it can potentially impact on research and practice. So whether we say an intervention or a treatment is useful or not can lead to future research in that area. It could also lead to implementation or de-implementation down the line of interventions as well. So what we choose has real tangible impacts in terms of what happens with the results of our trial. So given how important it is to choose outcomes correctly, you might be wondering, how do people typically choose outcomes? If we had a bit more time and it was a bit more interactive, I'd like to ask everybody how ye choose your outcomes, but I imagine I would get similar responses to what we have up here. So these are the results from a survey of trialists who published trials in quote-unquote major medical journals, so things like The Lancet, JAMA, New England Journal of Medicine. We were doing a larger review, and we also surveyed these trialists, and among other things asked them, well, how did you pick the outcomes for the trial that you included that was published in this paper? The top kind of most frequently endorsed one was, we looked at what was done in other trials and we picked our outcomes based on that. Following this, it was practitioner opinion, so maybe going to practitioners or clinicians or having those people on the team. Then there were the recommendations from professional bodies. Feasibility or pilot studies can be feasibility or pilot studies that are published in the literature, or they might be the feasibility or pilot studies that have led to the definitive trial. Systematic reviews was kind of similar to looking at the existing literature. Okay, so what do the systematic reviews look at? What do the papers in the systematic reviews look at? Much lower than this, or much lower than the most highly endorsed one, was patient and public opinion, so that was just under 40%. We see this increasing over time, but it's still lower than we would like, obviously. And then the last one, and Valerie alluded to this in Declan's recent paper, Claire's recent paper, was recommendations from funding bodies, was in a kind of 19%. Now this is from quite a small sample size, so this is very descriptive, but it's similar to responses that we've gotten in other surveys that we've conducted with trialists who've registered their trials on international repositories, as well as trialists who've submitted to different funding streams, so for instance in the NIHR. And the categories are not mutually exclusive. Trialists can use lots of different sources, but I suppose there's a few things that are important to note with this, that these sources are likely to differ. So what a a patient or a member of the public is going to say can be different from what a practitioner will say. It can be different from what a funding body or what a professional body might recommend. Similarly, if you're looking at what's been done previously, okay, kind of useful, but also what if what's been done previously isn't right? Or what if it's not best suited to your trial at your context at this point in time? So while it's important to consult these sources, the variability and the heterogeneity in terms of the sources can potentially be problematic if you're not doing additional things to ensure that you're picking the correct outcomes. And we see this kind of variability and heterogeneity in terms of where outcomes or the sources for outcome choices reflected in outcomes that are actually measured and reflected within clinical trials as well. So this is one of the first kind of major issues that I want to touch on in terms of outcomes in trials, and it relates to outcome heterogeneity, which is basically that there are inconsistencies and a lack of standardization in the outcomes that are being measured across trials, across multiple different health areas, and there's a lot of evidence to support this. So just as one example, this was a review that was conducted of over 8,000 oncology trials by Hirsch and colleagues, and what they found was that within these nearly 8,500 trials, 25,000 outcomes were measured and reported only once or twice. This isn't that 25,000 outcomes were measured and reported, these were 25,000 outcomes that were only measured once or twice. So this is so infrequently as to basically be potentially useless if you want to start pulling the information together from those 8,000 trials to make sense of what works for these outcomes. In addition to the fact that they're measured so infrequently, we can't really use them in an evidence synthesis, they also contribute significantly to research waste, because what do you do with all of those outcomes if you can't start to kind of bring them together? Similarly, in a smaller number of trials, in a more recent review that was conducted by Nicola Harman and colleagues, they looked at 138 diabetes trials. But proportional to the size of the number of trials, they found quite a large number of outcomes, so 1,444, with a range from 1 to 60. So again, huge variability. If 55 of the outcomes in the upper end aren't measured in the majority of the rest of the trials, you still have the same issue as you do with the 25,000 outcomes. What can you do with those outcomes, because there isn't sufficient data to start pulling them together? And when you have that variability, that there is such a huge range in terms of what people are measuring, you're essentially trying to compare apples with oranges, okay? That you're trying to compare very different things across different trials, which makes it very difficult and significantly limits our ability to conduct evidence syntheses, to pull the information together, to look at the outcomes, and to actually determine what treatments work, who do they work for, so with whom, in what contexts, and to actually figure out the mechanisms. So that's a significant problem, kind of limiting our ability to synthesize evidence, and also considerably contributing to research waste. Another problem that I want to talk about that kind of is at the other end of the selection of outcomes but is related to outcomes is outcome reporting bias, that I'm sure you will have heard of before. And it relates to publishing only a subset of the outcomes that are examined. So you decided at the beginning of your trial what outcomes you were going to pick, you ran your trial, and then at the end of the trial you decided you weren't going to publish all of the outcomes. And there are a number of reasons why people might choose to do this or may do this. So we know that statistically significant outcomes are much more likely to be published. Journals like things that are shiny and significant and novel and all of that. So if you're running a trial and a certain number of your outcomes are shiny and significant and others aren't, you might be swayed that way. You shouldn't be, but you might be. We also know there's a time lag in publishing null results. So you can get null results published, but it takes longer. Anybody in the room who's tried to publish null results will agree with me on that. It does take longer to do. Now, things are improving in terms of getting results out there with preprints and things like that, but there are disincentives to publish things that aren't significant and novel and shiny. We recently, there's lots, so this, a lot of the work has been on kind of by Kerry Dewan and colleagues, but we've recently conducted with a Masters in Public Health student in UCC who actually graduated yesterday, and we conducted a review of trials, behavioural health trials, to look at this outcome reporting bias within this particular area, because it's not typically looked at. So what we did was we had a look at differences between trial protocols or registrations and the final trial results. We also had a look at differences between methods and the results, and overall what we found was that across the trials that we looked at, 66% had a change in terms of the outcomes between what they said they would do and what they actually reported on in the results. Of these, 45% left something out. They said they were going to measure it and then they didn't, potentially because it wasn't significant, it wasn't shiny, whatever that might be. Over half added something in. So in the results, they reported on something they never said that they were going to look at in the first place, which raises a number of questions. And 17% changed the importance of an outcome. So something that they said was going to be a primary outcome became a secondary outcome, or something that they said was going to be a secondary outcome became a primary outcome. And that's really problematic when you think about the way that we use outcomes to power our trials. So we don't often have, and Darren will speak about sample size tomorrow afternoon, not specifically this, but if you didn't have statistical power to detect differences in your secondary outcomes, but you've swapped a secondary outcome into a primary outcome, that's very problematic. So there are lots of reasons why people engage in outcome reporting bias, but thinking about things like sensitivity, applicability, and relevance of outcomes to your trial aims at the beginning can help to kind of address some of this. But most importantly, it's around being transparent, saying what you're going to do, and then doing it, and sticking to that plan and being clear and transparent in terms of what you've done with your outcomes throughout. And then the final point is in relation to importance to stakeholders, and this is really important because we need to make sure that the outcomes that we're measuring are meaningful and relevant. So this isn't about trialists picking the results or the outcomes that they think are the most useful, but it's about actually asking people. So in the slide that I showed you earlier, consulting patient and public representatives was at about 40%, which is much too low. So in order for all of the trials that we do, all of the research that we do, it's for the benefit of patients and the public. So we need to make sure that the outcomes that we're looking at are the outcomes that are actually important to the patients and the public for us to achieve our aim as researchers. Just as an example of how this doesn't often happen, this is a review that was published recently by Sean Sherwick and colleagues, where they consulted with stakeholders who were healthcare professionals and patients, and they presented them with a number of breast cancer and nephrology trial outcomes, and asked them, do you agree with the primary outcome? And in 28% of the trials, the healthcare professionals and the patients agreed, which means in about 3/4 of the trials, the healthcare professionals and the patients said, no, I don't think that's the most important thing to look at. So there can be a disconnect there, okay? And again, that comes back to the relevance, that comes back to the importance, and it comes back to the usefulness and the potential for waste. So it's really important to include patient and public voices throughout trial design, but also when we're thinking about outcomes. One nice example of this is in the area of rheumatology. Up until patients and public were brought in, fatigue was not considered to be an important outcome at all. And when they spoke to patients and patients and people with various issues, they said, fatigue is absolutely essential. Why are you not measuring this? This is absolutely critical. So bringing in those voices to make sure that the things that you were looking at are appropriate and relevant. So Valerie's already mentioned core outcome sets. These are an approach to address a lot of these issues. So core outcome sets are standardized minimum sets of outcomes for what should be measured and reported in any trial of a specific health area. They are agreed sets of outcomes. They're agreed through a systematic process that involves evidence syntheses and consensus processes with stakeholders so that the stakeholders agree on what is most important. They're the minimum amount, which means that you can measure other things in your trial, but at the base you should be measuring and reporting these. The and reporting is important as well. So the COMET Initiative has already been mentioned, but the COMET Initiative provides a lot of resources in terms of developing core outcome sets, but also in terms of searching for core outcome sets. So if you're planning a trial, or if you're applying for a DFAT or something like that and you're not sure if there's a core outcome set available for your research area, you can search the COMET database and it will give you information there. If there isn't one and you need to go develop one, it'll give you information on that as well. Valerie put up an example of one of her core outcome sets earlier. I do think it's useful to see an example because sometimes it can be a bit unclear, like what do you mean? What is a core outcome set? This is one that was published very early on during the pandemic by Tong and colleagues that just outlines a set of outcomes that have been agreed by key stakeholders that should be measured and reported in all trials in people with COVID-19. And you can see they're very clear, this is what you should measure. So core outcome sets represent the what. They don't tell you how. We're not thinking about how to measure respiratory failure with the core outcome set. We're just saying you should be measuring this. And by using core outcome sets, we have a number of benefits for trials. So we can improve evidence synthesis because we've standardized what people are measuring, and if people are all measuring the same thing, we can start to compare and contrast across the different trials and actually see what works or what doesn't. Through this, we can start building empirical bases to better inform our trials, to better inform what we're doing in terms of treatment. We can reduce research waste because we don't have 25,000 additional outcomes that are being measured for no real good reason at all, and because we've standardized what should be measured. Really important, they're relevant and meaningful to stakeholder priorities because we've included stakeholders throughout the process. We've asked them what's important. It's not just researchers coming together and making an agreement, it's including all of the relevant stakeholders throughout. They can increase openness and transparency if and when researchers say they're going to use a core outcome set, they use all the outcomes and then they report on the core outcomes or report on why they could not measure all of the outcomes included in a set. And they have the potential to reduce bias, because if you say you're going to measure a core outcome set and then you subsequently report on the full core outcome set, that can minimise bias as well. Despite how useful they are, there are a number of challenges for core outcome set use. The people are not using them as much as they should. So these are just two examples. One is a review that was led by Paula Williamson, who leads COMET, where she looked at Cochrane systematic reviews, and of 100 systematic reviews, only 7 of the reviews used core outcome sets, and Cochrane endorse core outcome set use as well. So I think this is increasing now, but at the point in time when this was published, it was quite low. Similarly, in that review I mentioned earlier of the major medical journals, 2 of the 95 trials that we included used core outcome sets. So the use of them is quite low. And there are a number of reasons for this. People have poor knowledge about core outcome sets. They don't know what they are, they don't know how to find them, they don't know when to use them, they don't know why to use them, which is part of why I'm including them in the talk now, so you can all go away and know what they are, where to find them, and why you might use them. Relevance and scope. So some people might not know if core outcome set is useful for their trial, or they might think that perhaps it's a little bit outside of the scope. The COMET database provides a really useful resource in terms of finding and identifying core outcome sets that are relevant in terms of scope. So it can be kind of overcome that way. Lots of trialists want to use their own outcomes. We've done it before, we're going to do it this way again. Or we don't want to be told how to do it. And that kind of, I suppose, approach forgets that things like core outcome sets are the agreed most important outcomes that should be reported. And then the final issue, there are lots of issues that I'm just highlighting 4 here, but it relates to measurement. So people see a core outcome set and they think, oh, there's far too many outcomes, can't possibly measure them all. So the examples you've had both had 5 core outcome sets in them. There are core outcome sets with far more than 5 outcomes in them. But measurement issues can kind of impede people in terms of actually engaging with core outcome set use as well. Which nicely brings me on to the last bit that I'm going to talk about today, which is around measuring core outcome sets, or measuring outcomes in trials. So while core outcome sets talk about what to measure, we also then need to think about the how, and Valerie alluded to this with her core outcome set. It's all well and good to say you should measure this, but if you haven't given trialists the tools or given them guidance on how they should actually go about doing that, as you saw on the previous slide, they might be disinclined to do so. We also know that there is significant heterogeneity in how things are currently measured across trials. So we have the same problem with the what that we have with the how. I'm just going to give you one example here, which is a review of 10,000 trials just in the area of schizophrenia that used over 2,000 different measurement instruments. So these are like patient-reported outcome measures or like clinician reports, but over 2,000 different measurement instruments. I think there was a new measurement instrument introduced every 5 papers they looked at or something like that. So again, significant heterogeneity, significant potential for research waste. That again just poses all of the same difficulties that we have with the what. So it's really important, similarly to when we're thinking about what we should be measuring, to think about the appropriateness and the relevance for how we're going to measure things. So this relates to the stakeholders. So again, it comes back to this issue around patient burden, what's acceptable, what's feasible to patients and members of the public, also to the clinicians and the healthcare professionals who may be involved in your trial. So a lot of data collection happens in clinical sites. Is that data collection appropriate and feasible to those stakeholders as well who are going to be facilitating the data collection? Are your measurement approaches suitable for your research purposes? Are they going to meet your research aim? Are they going to allow you to actually collect the data that you need? And then tied to this are the measurement properties. So are the tools and instruments that you're going to use, whatever those may be, are they reliable, are they valid, and are they going to be responsive? And there are lots of ways that you can look at that. The COSMIN Initiative, which has already been mentioned, provides a lot of useful resources for how we can actually evaluate how we might go about measuring outcomes within trials. So they provide support in terms of identifying the most appropriate measurement instruments, also evaluating measurement instruments that you might find. They also, similar to COMET, have a really useful database where you can go in and you can have a look at studies that have already been conducted that have evaluated the measurement properties of different measurement tools. So it provides a really useful resource to help guide what you're going to do and how you might measure your outcomes. And I'm nearly finished, so I'm going to use my last kind of 2 or 3 minutes. Well, I've got one more slide after this, but just to do a quick plug that if any of this is interesting to you, there is a research position currently open on a HRB funded project, so the standardised measurement for childhood obesity prevention, which does a lot on this kind of measurement piece with some wonderful, excellent people who are sitting in the room here also. You can follow it at the QR code, and I'm around for the day if anybody is interested. Come up and we can have a chat about it afterwards. So that's my blatant plug. Okay, last slide. Outcomes in trials are absolutely critical that we think about them and we give them due consideration because they impact on the trial design, the conduct and the evaluation, possibly in more ways than we might think about when we're just thinking, oh, I'll get to that at the end of the trial. There are lots of challenges and issues that exist, and I've just highlighted a few of them here today. But there are solutions available like COMET and like COSMIN, so please use them and don't just run blindly into a trial and pick whatever outcomes you think look the shiniest. So that's it for me. Thank you very much.